Scott Hartronft. I'm at least now been an adopted Texan and local person. So after having moved around with the military for many years, I decided to stick it out here. So it's a really nice place. I enjoy it. So today's talk is on informed consent. And what we wanted to start off with is kind of the timeline and history of informed consent. Because what we use nowadays, or what we consider normals or standards, by no means has that been that way in history. Actually, if you look in the pre-20th century, the Hippocratic tradition had benevolent paternalism. And actually, as one of the sayings, speak to the patient carefully and adroitly, concealing most things. They actually believed it was providing a benefit to the patient and avoiding harm or chief concerns. They actually thought, a lot of times with the paternalistic view, that an informed patient might actually be too afraid. They might not be able to make the right decisions. So the idea of autonomy wasn't quite really, had not reached fruition yet at this point. So again, many times disclosure was considered harmful. Only until the early 1900s, consent was becoming an event, with some of the early cases being in 1906 and 1920. And at that point, they decided consent was necessary by court cases, but it was more of an on and off thing. It wasn't really what we think of as informed consent. So a person may not, the doctor asked him, might have asked the person if they could do surgery, but they didn't go into the risks and the benefits and, go into a true informed decision. So these were some of the major milestones. And some of these were when a woman sued her physician for removing her uterus without consent in the case. And the next one was actually performing a surgery on a child without parental consent. Now in the 1950s is when we start kind of getting to the coining of the phrase informed consent. The physician has the duty to tell the patient necessary facts prior to the treatment. And this court case, the Salgo versus Leland Stanford, in 1957 was the first to coin the term informed consent. So it wasn't until 1957 that people kind of solidified not only getting consent for an overall procedure, but also having informed consent such as risks, benefits, and a choice. And then in the 1970s, it was even further that if consent was obtained but it was not informed, it was just the same as if consent was never given. So it actually not only placed the burden higher, but just said basically nulled any consent that didn't really include true informed consent. And these were the cases, one in Rhode Island and one in New Mexico. In 1977 in Texas line, legislature passed the Medical Liability and Insurance Improvement Act, Article 4590I, and it put into writing the legal requirements for physicians when it comes to informed decisions and informed consent. And it basically put the premise, as you can say, in a suit against a physician or healthcare provider claim based on the failure of the physician involved in the medical care. The only theory on which recovery may be obtained is that negligence in failing to disclose the risks or hazards that could have influenced a reasonable person in making a decision to give or withhold consent. So it gave the physician presumption whenever it went to court if they definitely had a true informed consent document. So it really then became a negligence issue on that part if it was in place. In 2003, the Informed Consent Statute had been codified and was moved to actually a subchapter in the Texas Civil Practice and Remedies Code. Now, the statute on the Texas Informed Consent, the language seems very simple as you can read in that section, but really, of course, whenever you get down to specific cases, it can be drawn in many different directions. It's hypothetical, requires a reasonable physician with a reasonable patient at a reasonable level, and it normally would or would not tell a patient about any treatment. Aimed at the adequacy of the informed consent is where we really kind of went towards in most of the cases. Not only did we go through, sign a form, got slammed into the chart, and moved on, but really did the patient have that read to them at a level they understood, and then have the offer to decline or not, and to make a reasonable judgment if that were to be something they want to have done to them. And if no consent is obtained, the physician is potentially liable for neglect and possible battery. By statutes in Texas, the consent is considered effective if it's in writing, it's signed by the patient or person authorized to consent, signed by a competent witness, And the consent specifically states the risks and hazards involved in the care of the procedure and to the degree required by a Texas Medical Disclosure Panel, of which I'll mention later what that is. Elements of an informed consent, though, after following the prior speaker, is good timing, is the person needs to have medical decision-making capacity. Without that, a person can actually have different phases. You've got to remember, competency is a legal process, capacity is more of a medical, and a person can have medical decision capacity and technically be incompetent. And so it can be, like even in incompetency, sometimes when it comes to, it's broken down by specific tasks, usually in Texas, whether it be financial, whether it be health care, or other issues. So it's not a completely whole blanket unless that's specifically sought and also approved. But again, that competency is legal, whereas capacity is more of a decision made on the spot with medical as to if they can make the decisions. And really what we look for is if the person is able to understand their disease process. Can they tell me what they have and why they're here? Proposed therapies and alternatives. What is the therapy that has been offered to you? Are you aware of any alternative therapies? And then advantage, adverse effects, and potential complications of each therapy, so that they can let me know that they understand if they have X surgery, Y could be an outcome. Although it's not something we necessarily want or even occur very frequently, we need to let them know that this is a potential so that they can make an autonomous, self and fully informed consent. And also they need to know the course of the disease without the intervention. And that's totally in their rights. If someone has capacity, I basically say if they're over legal age and have capacity, a person can make decisions, although some people might think it's a bad decision, they are able to make a decision, as long as it doesn't hurt others. So the course of the disease without intervention. And we have to respect that a lot of times in the aging population, because sometimes some of the treatments may be able to extend life, but to what advantages we need to be clear with them and things. So we're not judging what they just decide to do, but we just want to make sure they have an idea of whatever choice they do have, we'll have for them. And the patient's ability to communicate the decision. Otherwise, you need to have a surrogate or some other means of knowing what they want to do. Now, decision-making capacity, I won't go into it since y'all just had a good talk on that. Really, it's the ability to understand the disease and the treatment options. And then beyond that, the ability to understand the consequences of choosing each of the options. Not just saying you have a tumor, you need to have surgery. No. What is going to happen to you if you don't have surgery and you have a tumor? The person needs to be able to make a decision on either of those courses. And also, when it comes to like cancer, they need to know, is it more advantageous just to do chemo, or is surgery always indicated, or one before the other? And give some outcomes, actual numbers for these people to know where they're at. Can I say that 100% of the time you're going to do this? What I can do is say with this particular protocol, 90% of the people do this, and and 10% of the people do that. Do I know which of those sides you're on? No, but I'm letting you know which of those you need to be aware of. And also the ability to evaluate the personal risks and benefits of each of the consequences set to their own values. A person who's, say, 80, who's diagnosed with prostate cancer, you can't really assume what they would want. Some people would want everything done, and that's within their right. And others would like to just find out what the course would be like, what's some more milder alternatives. And again, as long as they're of legal age and capacity, then that's their decision to be able to take any of the alternatives, and even to readdress that at any time. They can change their mind. They're not set on a forever autopilot once they make a decision. Same way with advanced directives. Those can be readdressed as things change in their lives to bring that back up. So it's a dynamic event. And it also means that the patient can understand and explain the options and their implications, and actually kind of a rational reason why they chose it. Even if it's based on religious reasons, personal values, whatever. It helps to get a feedback besides just, yeah, I want it done. Well, why would you like to have it done? Well, I have some young grandkids, and I would like to do, I think from the decision information I've had, the best chance I have to see them maybe grow older is to have this done. Okay, we can understand that. But again, so you really not only just say them to say yes answers, you got to have them give you a little longer of a reason to understand, to really know what they're thinking. And the legal definition of capacity for Texas in the Texas Administrative Code really is a patient's ability to understand the nature and consequences of the proposed treatment, including the benefits, risks, and alternatives to the proposed treatment, and the ability to make a decision whether to undergo the proposed treatment is how it's set out. Now, when it comes to mental status impairment, we sometimes in aging think of just like with dementia or Alzheimer's. But you got to remember, if a person's under the influence of another medication or have an unclear sensorium, regardless, at the time you're seeking consent, it's the same as impairment. So you need to, if there's any doubt as to the person's mental status or sensorium, you need to have it documented. You know, that you got the consent before you started pushing the anesthetic agents in their IV. You know, after you've kind of shoved a lot of stuff and the guy's going off into la-la land, it's a little late to be kind of getting a scribble on the line. So you really, it's not only important to have the form in there, but if there's going to be a question later, it's nice to put a note that this was the time on it and it was 10 minutes prior to any anesthetic agents. Also, if the person comes in inebriated, you need to also make note of that. So, you know, just the fact is later on that a person, if you do have a consent, it is in the physician or provider's interest to have that, but still the presumption can be overcome if there are things such as, well, he was obviously staggering and, you know, his blood alcohol level was 3 times the legal limit. Well, that's pretty well easy to, you know, at least overcome on when it would be considered if he had the capacity. So helpful documentation, as I said, is timing of consent in relation to mood-altering medications. Document the patient's mental acuity at the time. Was he alert? Was he oriented? Was he able to talk in full sentences? He spoke his risk benefits. Things like that could help. Possibly also incorporate in the consent form that the patient fully comprehends the risk and benefits of the procedure. You know, things like patient verbalizes an understanding of the risk and benefits of the proposed procedure and chooses this based on their value system and choices. Again, it's just something else that you put in there because if a lawsuit or something does come up in the future and it's 2 or 3 years down the road, you're not going to necessarily remember, and your credibility on being able to remember is going to be kind of concerned. I don't know about everybody else in here, but if you've seen 1,000 patients since then, I'd be kind of wondering, you know, are you Superman with the memory thing going on there, or what? You know, it's just, and you can't just say, well, a lot of people default to, well, that's my usual practice. Well, that's what I always do. Well, again, if it's not written, it didn't happen for the most part. So you need to just remember that as well. Usual practice is nice, but everybody has a weird day where nothing's usual. So you got to keep that in mind. And also language barrier. You got to make sure that you're presenting to this person in a language as well as an educational level in which they can understand what you're talking to them. If you have a form that's at the PhD level, you know, most of us probably won't be able to understand it. So you really want to bring it down into layman's terms so that they understand it, because a lot of folks can be embarrassed. They don't want to admit they don't know what a certain name or word is. So some of the sweetest, most polite people will go ahead and nod and not have a clue what you just said to them. So you got to make sure that if there's in doubt, if they know a word, just ask them, you know, are you familiar with that word? And can we use that on something else? And then also if you need a translator, it's important as well. And to document that. If the person's primary language is Spanish and there's any concern, then the person had a translator. And the Texas Medical Board also has a lot of the consent forms in Spanish, so that's helpful. So the TDH consent forms are also in Spanish, translators are available, and consent in layperson's term, and usually the 6th grade level education is what most people advocate on a reading level. But it varies, you know, where you might be at. Now, also you got to keep in mind disability, ability, and dependence. You got to take into account hearing and vision disabilities. Was the person able to hear what I told them, much less see the consent form? So you got to breathe that, make sure that's addressed. And also implications to aftercare, resources for stability. Are you off? Okay, you say they're going to need this surgery, and they're going to be waylaid for 3 or 4 weeks, and they're not going to be able to move. You need to give them some options of what they're going to do, because that may actually preclude them from being able to have that surgery if they live alone and have no family support or anything going on. So I do an extension as to you know, why did you turn this down? Was it because you're worried about something after the procedure? So I think it's important to kind of keep that in mind. And so social work a lot of times is very helpful. They can address a lot of social issues that we may not be aware of, and kind of also find resources for the people in the community. And also larger print forms for age groups and certain clinics is important. And of course, they're an attachment to the Texas Department of Health, and what their job was to do is kind of review all the medical procedures, the common ones, and then decide which ones were in a list of ones that required a full informed consent in items A, and then in items B of tests that don't. And as you can see, A are those that require disclosure, B do not, and also identifies the manner in which those risks must be disclosed. So if something's on the A list, it also says what specifically needs to be addressed in consent for that to be a valid consent form. So it does right into that. They have created specific consents for the List A procedures. There's also one for radiation therapy, electroconvulsive therapy, and hysterectomies that are in the provided. And since 2004, a patient contemplating an abortion must also be provided informational brochures and sign the consent created by the Texas Department of Health prior to that procedure. So just to give you an idea of a List A procedures, like anesthesia, an epidural, a person needs to address, it's practically written into this form. They need to address persistent back pain, bleeding, epidural hematoma, infection, potential to convert to a general anesthetic if the block fails or procedures outlast the block, and possible brain damage. I know it's kind of strange, but and a joke, we were always taught when I was in training, just always add death. Regardless. I don't care if you're drawing blood or you're doing surgery, just blah, 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 and death. So it's kind of funny how things have evolved. But, you know, because trying to explain that to the patient too is like, I thought you were just going to take some, you know, put a line in where you could get better access. Well, we are. And you'd hate to say, well, I'm usually pretty good at it. I'm joking. And then on general, you got to say, like permanent organ damage, memory dysfunction and memory loss, and things like having a coronary artery bypass valve or valve replacement. You got to go down the list like heart attack, bleeding, kidney failure, stroke, sudden death. At least you're covered on the death thing now already. You don't have to just add that in. Infection of the chest or wall chest cavity and valve-related delayed onset infection. So if it's an A procedure list, Texas law says you definitely have to give disclosure, and it actually tells you what you need to disclose. You can always add to it. You know, no one's ever going to hurt you for adding an addendum to something, as long as it really pertains to it, though. So hopefully y'all can read in your handouts, but the entire list can be found in this administrative code, and I put the link in as well. Now, examples of List B procedures not requiring disclosures, anesthesia like local, like if you're doing a local little lidocaine somewhere. Other forms of regional anesthesia. I guess I was raised in a different age, so I can almost get consent just so I didn't walk through the door anymore. So, short of just drawing blood, most of the things I do, I just go ahead and do. But is it required? Not necessarily or directly by the Texas law. Such as cardiovascular system, they put excision and ligation of varicose veins of the leg. I was like, oh my goodness. No other procedures that assigned at this time. Digestive systems, and appendectomy, hemorrhoidectomy. I'm just listing a few that were on there. Colonoscopy, tonsillectomy, and adenoidectomy. So again, these are just suggestions and what they've decided, but I don't know of many people who don't go ahead and get a consent on it. So mine is pretty well if it's beyond just the normal blood draw I tend to get. Now the bad thing though with this is of course now you have a List A and a List B. So anything that's not on either list, what do? So there's this hypothetical List C. And what they've gone into is a physician is still under the duty of disclosure, otherwise imposed by law. What does that mean? Well, basically, a case said that they must still identify the risk or hazards that could have influenced a reasonable person to make a decision to give or withhold consent for the decision. And informed consent is patient-focused and not physician-focused. So again, the patient has to understand. Now, only material risk must be disclosed. The risk must be inherent to the procedure undertaken. We can always say, after you have your arm worked on, You don't have to go into it, but you have the chance of maybe an asteroid hitting you on your way to the car. You know, you want something that has something to do with what you did. Even though the risk is more harmful of someone getting on the interstate and driving home than many other things we do to folks, you know, so let's just keep in mind it really needs to be kind of inherent to what's going on. And it's reasonable that for the person that can be influenced decision to undergo a treatment by disclosing a risk to the treatment and that it must be disclosed. So again, most people treat List C as a List A because it's not clearly defined in any of the statutes. So therefore, what's an extra few minutes to do informed consent? It'll save you many years of anxiety. Basic comment advice for consent regardless of list, again, acquire written consent, make sure you're doing language and education level appropriate consents. Because I don't know if you've seen some of those consent forms, they're front and back and 4 pages. I mean, that's like a novella to most of us, you know. I look for like the highlights on, you know, CNN.com, much less read a whole article. So it really takes a lot of reading and actually inflection at a time someone might be really stressed. You know, someone might be about to have their, for all they thinking, their body violated and, you know, all sorts of things. So you got to think of the mentality the person's in at the time as well. And the layman's terms and reasonable acceptable risk involved. And also document the mental status again. You know, was the person alert or in a verbal? You know, kind of, because again, down the road you won't remember. You'll say, yeah, I probably would have noted if they weren't. But that doesn't really sound very good if you're on the bad side of the bench. So you really need to let yourself know. And I just consider the medical chart a time capsule. I mean, it's something to say what you did, your rationale for doing it, and what you did could have been perfectly fine, but if it wasn't there for the reviewer who's blinded to what you were doing, then it still could be considered wrong, if not by lack of documentation. So we try to feed that into the minds of our fellows and residents. Now, the physician so what does a physician really get from following the statutes? It's a legal presumption created the physician did not neglect his or her duty to disclose. What it is the opposing party at trial can try to rebut the presumption, but the opposing party has the higher burden to produce evidence to overcome the physician's set legal presumption. Now, if the physician does not follow the statutes, it's actually the opposite. That creates the legal presumption that the physician could be negligent in obtaining consent. So therefore, anything that would evolve from it. And actually, then the burden is actually on the physician to try. So the difference between the two is how many lawyers, I guess, you got to hire. And from what, you know, and how much TV time you got to do and plead for. But really, you know, so by following the laws, it gives you at least a presumption. Can that be overcome? Yes. But at least you have the side on your side for the other parties to have to overcome. Now, minimal requirements, at least when it comes to clinical research, we do a lot of research. So, first of all, you need to have in the consent form that participation is completely voluntary. They are by no means required to do this to gain any treatment, to gain any medications, to gain anything. This is truly, they're being benevolent, a person in society that is freely willing to participate and is completely voluntary. They need to know why the research is being done, not just the fact that I want to give you a purple pill and see what happens. You know, I need to know, are you trying to save the world from malaria? Are you trying to use this pill for diabetes? Give me some idea. I know you're not, that's why you're investigating it to see. Also, what they hope to accomplish. Again, not only are we looking at something for diabetes, but are we trying to improve and decrease the risk of amputations by doing this? Are we trying to improve the blood glucose control? And also the risk to the patients. And it depends what phase of the trial and the clinical trial. Like phase 1 trials, a lot of times are really looking to find symptoms and how well a person can tolerate a medication. So at each level of the phase in the trials, they need to be understood what that phase is really meant to accomplish. Because in phase 3, there's a lot more expected than in phase 1 for the patient. And other treatments that are available if the patient decides not to participate. And verification that they have the right to leave the study at any time. You can't feel any informal or direct or indirect pressure that, you know, the whole world's idea of diabetes will forever be ruined if you drop out. You know, or you're a bad person if you didn't follow up. But, so you need to just let them know, again, thank you for being part of this research, and you can leave at any time. Now, delegation of informed consent usually comes up quite a bit. and risk management. I used to do a lot of that with the military. And what really and I was a nurse before I went to med school, so I kind of have I've seen both sides of the fence, but a lot of people like to try and have someone else fill out the consent form. Well, the bad thing about that is legally the physician that is going to provide the procedure or treatment is the one ultimately legally responsible for that consent form and the informed consent. They may have the nurse fill it out or sign it, but they need to ultimately review it and then again make sure the patient did read it, they did understand it, and then co-sign it or at least make sure that everything is fine. Just being able to say, well, the nurse did it and I didn't have a chance, that's not it. You've only opened a second party to possible implications by having done so. So really it's still the surgeon or whoever that's going to do the procedure or treatment's responsibility at the end of the day. Again, they can be a reviewer and verifier with the patient, not with the nurse after the fact, but with the patient before the procedure. And that's when you mark the right leg, kind of right side, right procedure, right thing. That's usually when you hand the Sharpie pen out and you kind of talk together. So, so again, having other healthcare providers do that really just opens up to others to legal implications. Now, some of the exceptions, of course, are emergencies to requiring consent to release of information, and that's medical or law enforcement personnel. If a physician knows that there's imminent physical injury to self or to others, an exception. Government agencies, of course, can really look about anything they want to. Audit and research personnel, if it's within the area. Necessary persons, corporations, or agencies, such as billing through insurance companies. If they need a certain kind of coding to find out if they really needed to pay for that procedure. And other persons who have the consent of that person are authorized. And other physicians or personnel under the direction of the physician. And again, they need to be in the direct care of the patient, not just someone who was bored that day and wanted to read some charts. Informed refusal, we got to keep in mind as well. Because a lot of times, if a patient doesn't want to do a procedure, again, that's fine. It's a non-judgmental issue, but you still need to document some things. Because as well as informed consent, there's also informed refusal. So when to document, and again, you don't write non-compliance. A person deciding not to have a procedure is they decided not to have a procedure. It has nothing to do with compliance. So again, you need to be non-judgmental. And you need the patient who declines indicated medications, routinely miss office visits, or defer or refuse recommended diagnostic testing. And part of that's documentation. Again, it's just like informed consent. They know the risks, the benefits, and for whatever they decided, they chose not to do it. Again, as long as they're of legal age and capacity, you just document. Autonomy still trumps many things in our society. So as long as unless they're a clear threat to themselves or others by having done something. Later on, the patient, if you don't do that, could argue the decision to decline the test, visit, follow-up, or medications were not based on an informed consent. So basically, they could say, well, they didn't tell me I could lose my leg if I didn't treat my diabetes well enough. They didn't tell me that I could lose my eyesight if I didn't do this. I didn't know I could lose my kidneys. Things like that. So informed refusal, again, just let them know risk benefits and you let them know and you document. Now again, when documented, you want to say what was offered and that you identified the reasons that it was offered. I need to take out your appendix. It's inflamed. There's a chance that you could become very sick. It could rupture. Identify the potential benefits of having the procedure, such as not having the appendix rupture and not having peritonitis and other issues. And then note the patient's been told of the risks and not accepting the treatment, such as, of course, death. And I don't put that on everything. But, very ill, high illness. And clearly documenting, the patient, I know people make fun of, probably I write this a lot, patient verbalizing understanding. Well, that's important in the sense that they were able to give the feedback back to you. And it made sense. Not just they nodded or showed or just walked out the door. Identify the reasons the patient states that they didn't want it. Well, I don't want a scar. Well, you may have to give up your modeling days, but, you really need this. I can understand where you're coming from, but I still want to let you know the gravity of the situation because you want to make sure it's just not a denial thing that you need to just work through a little longer. And again, so find out the rational reasons and also have a witness to the refusal just like you would with the consent form. Again, it just protects you and others, and then that way, in 2 or 3 years, a lot happens, so you can't remember stuff. So make your time capsule good, that you can make some sense, and other people looking at it. You can't say, well, I always talk to my patients, and I didn't think it was meningitis because of this, or whatever. Just say, this is why, and so it's linked in there. It doesn't have to be elaborate or an essay for a literature book. It just needs to have your rational reasoning on why you went to one thing or the other. Now, blood transfusions always come up a lot of times in arguments. And 4 important areas to address. Again, you need to let the patients know that blood testing has not evolved to the point that all contaminants or infectious agents can be detected, and each unit of blood can carry a risk that the patient will be exposed to a potentially lethal agent. And we actually, most of the consent forms have the percentages of how many, the chances of getting it from a blood transfusion for the individual illnesses. But again, it's not a perfectly clean, unless it came from you, then you don't know for sure what other things might be in it. So we don't have tests for everything, but you just need to let them know that. It is significantly decreased and very low, but it's important to let them know that. Blood transfusion has the potential for causing a blood or body reaction that could result in potential injury or death. And that's even if it's the right blood, they could still have a reaction to the blood itself. So they need to know that. In the lab or other errors have in rare instances resulted in patients receiving incompatible blood, which could potentially result in injury or death. And then you explain what we have in place to prevent that, such as we have 2 people looking at it, we have the bags marked, we have the patients. And also the actual physical process of giving a blood transfusion can potentially result in nerve damage, infection, or basically putting an IV. Even if they do fine with the blood transfusion, they could still say they were locally harmed by having had the larger gauge needles placed. So I think that really ties a lot of things together in a good informed consent form for blood transfusions. Again, it requires the patient to be in an incapacitated state. And also it requires no other persons who are authorized to give consent are available, and there's no time for a search for such individuals. So if it's truly a life or death situation, gunshot wound, something like that, you take care of it. Now later on, if they want plastic surgery to come in and do a little suture, subcutaneous suturing so it looks prettier, you just got to make sure you do the right thing. So documentation of the emergent condition and other actions needed, and if you tried to contact people, it's important. Who, when, what number you dialed. You need to even have the number dialed, because if you got bad information, it's better to know that this person may have given you wrong stuff. As for surrogates in Texas, if someone doesn't have an advance directive, the list of adult surrogates who can consent to medical treatment on behalf of an incapacitated adult in the following order: the spouse, the adult child of the parent acting as the sole decision maker with the permission of all other qualified adult children. That doesn't happen often. A majority of the patient's reasonably available adult children, not just the reasonable children, the reasonably available children. I'm joking. Family meetings are somewhat entertaining, but it makes your family look so much normal sometimes. There's no such thing as a normal person, by the way. And then the patient's parents, if they have no other people in the significance chain before that. And then someone who the patient is clearly previously designated to act on their behalf. Or the patient's nearest living relative, or per Texas law, even a clergy member, if you get down that far down the list. Now, the thing a surrogate cannot consent to are certain treatments, such as voluntary inpatient mental health services. Not very voluntary if the person's incapacitated, and a surrogate is making the decision. They can still be put into inpatient, but it wouldn't be voluntary. Electroconvulsive therapy is listed, as well as the appointment of another surrogate. So a surrogate can't just say, well, now I'm going to make another surrogate. It needed to have been that original surrogate. And also the decision to withhold or withdraw life-sustaining treatment. Again, just by being their surrogate doesn't necessarily. So advance directives are very important. I'm not a poster child. I don't get any money for them. But it is very important to put your decisions on paper. And now, other states. I heard there were some folks coming in from other states. So I wanted to kind of look at the difference instead of just shoving Texas at you. And they were in the handouts, the single-page handouts that they were walking around with. So again, some of these states I haven't ever practiced in when I was in the military. So y'all have job security, trust me, if you're from those states. Now, in California, they actually have no statutory defined definition of informed consent, but it's been discussed well in case law. Generally understood that a patient who receives sufficient information to make a meaningful decision regarding their own health care. Simple and common procedure exception when risks are commonly understood to be remote, such as blood draw. The doctor does not need to discuss the risks and benefits. And emergency exceptions, of course, immediate treatment needed, and these fall under the California Business and Professions Code in that state. It's kind of interesting, in California there were so many more environmental laws, and there's more restrictions on your car than finding a definition for informed consent. I thought that was kind of funny. I'll pick on each state as I go through. Don't throw me. Arizona, it was actually kind of difficult because they have so many rules because they have osteopaths, allopaths, naturopaths, and I forgot what because of all the complementary and alternative medicines that are focused out of Arizona, they have wazoo stuff. I mean, everybody has something. So I was just kind of dumbfounded by the amount of stuff there was out there on different, and all of them a little bit different. There's a little twang to each one. So, but the one for the medical physicians, physician advising a patient requires a proposed medical procedure, alternatives to the procedure, all associated risks, possible complications, obtaining an authorization of the patient or the patient's representative for the procedure. And I listed the side of the article to the Arizona Administrative Code. So it was just kind of funny each state when you start kind of digging through their intricacies. Now Ohio, the physician's duty to obtain informed consent is governed by common law and statute. The duty to disclose the information on which consent is based may be discharged orally or in writing. The Ohio Supreme Court has held that under common law, a physician obtains, when the physician fails to disclose to the patient and discuss the material risk and dangers inherently and potentially involved, if any, like unveiled risks and dangers, a reasonable person in the position of the patient would have decided against the therapy. So basically, it just says that under common law, a physician fails to obtain informed consent when they don't disclose certain things that an average reasonable person should have to decide whether to or not to have a procedure done. And again, most of their, I think I went on to another slide with Ohio. And then again, while a physician may discharge the duty to obtain informed consent orally, statute provides that written consent to a medical procedure is presumed valid and effective if. So it gives you the both. I always rather write it. I'm sorry. Verbally is nice, but writing always helps you a little further. So especially years down the road, when a reasonable person doesn't remember crap. I mean, it's really hard to, say, oh yes, I always ask all my people before that. It just doesn't sound well. So if you set it in there, again, have the consent form set in general terms and nature. So this is kind of how they set it in their codes in Ohio. Now Tennessee. Legal informed consent involves several concepts. The patient must be presented with sufficient information to allow truly informed consent to treatment. The content of the explanation should be somewhat reasonable, prudent physician. Again, find me what a reasonable, prudent physician is, but I'll give you a quarter at least. Would say under similar circumstances of this or a similar community. And it's a process, not a pre-printed form, and that's something I really like to explain. It's not, when I was a med student or an early nurse, it's basically you got to fill out this paper before they go somewhere. And it really didn't delve into you that it was more than, ma'am, could you just sign on the back of the page? You get really, until you get down to it, they need to have read it or you've read it to them. And again, ask them all the aspects of risks and benefits. Again, not just putting, infection, death, blah, 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 and then just having them sign on the extra back page. So the informed consent is considered consent, so give patients time between the hearing, the information, and signing the form. And I put that down there. Theirs is a little longer. Sometimes I get a little rambly on slides, so I apologize. And then Tennessee continued, proper informed consent and its medical record documentation includes, but is not necessarily limited to, and again, they kind of list what they, but at the bottom it says, not every treatment requires informed consent, but professional ethics suggests that you provide it routinely. Discussion of informed consent must be documented and the treatment could cause serious effects. Remote risk must, however, be disclosed if they carry the possibility of life-threatening, catastrophic, or severe consequences. So each state, whether it actually sets a definition to define, or if it's more of a collection by a case series, basically, then they kind of come to a conclusion. Now New York. At first I was going to put up here, you have job security. It was kind of hard to really get into some of the code in New York. Anybody here from New York? It was difficult. I mean, I like a challenge, so activities. So basically, their side is to receive, a person should be able to receive from his or her physician information necessary to give informed consent prior to the start of any non-emergency procedure or treatment or both. And it shall, as a minimum, provide, again, specific procedures, reasonably foreseeable risk, as a reasonable medical provider under similar circumstances would disclose in a manner permitting the patient to and refuse treatment, and they should have the option again to refuse treatment to the extent permitted by law and be fully informed of the medical consequences. And that was under one of the sections of the New York State laws and regulations. So again, I tried to, once I found out what states most of the folks were coming from, I wanted to add a little bit about the differences, because each state, since I've been in different states, you kind of find out, just like with involuntary commitments, you go know these states and places, you can, it's very different on what you, so you have to understand what state that you're specifically in. So I started off with Texas, which is the majority of the folks that would be here, but I also wanted to give some libs if there were any slight variations, whether there was a fine term or an informed consent in as many of the states as I could from other attendees. So, is it as clear as mud now? Any questions?
I have a couple questions.
Yes, ma'am.
And two of them are just clarifications. The first one, right now we have all of these issues in the emergency room. We're trying to get the balloon up in a case of, hi, with all the, can you hear me?
Yeah.
How do you turn it on? Sorry.
We can hear you.
Hello?
Yes.
Okay. In the emergency room, one of the quality issues is trying to get the balloon up in a for MI within a certain period of time. Okay. And so in those situations, a lot of the protocols have the emergency room physician consenting the patient, and then the cardiologist actually doing the procedure in the efforts to hone down. Ultimately, it is the cardiologist's duty to consent. If the emergency room physician does it, he or she embraces some of the risk involved. Is that correct?
Yes, and what, I mean, even if they don't themselves sign the form or have the patient sign it, they need to review it and make sure it's A, complete, and then they usually co-sign it, is what I usually advise. And that way it just shows that A, they were aware that one was completed, because just for a quality assurance measure, you know, if you go back and you find out things have been timed and find out it wasn't caught before anesthetic was given or something, you need to have each person that needed to sign it, sign it.
The second clarification is, in the Consent to Medical Treatment Act, it discusses the surrogacy line. However, if the patient is incapacitated and has a medical power of attorney or a guardian, those would supersede that surrogacy list.
Yes.
In that situation, there is a mnemonic that I made to help our ethics committee work with that. It's good medical sense calls prudently for other nearest related contacts. So good correlates to the guardian, medical for medical power of attorney, sense for spouse, children for one child acting for all the others or the majority of the children, prudently for the parents, and then all on the same rung, the friend designated before the patient became incapacitated, other nearest relative for the other nearest related, and then contacts is for clergy. And then the third question I have, when you're trying to find the next available relative in a patient who's incapacitated, what is our obligation as far as, you know, that's considered the medical emergency where, because we can't make decisions, we have no decision maker, and it's not bona fide life or limb, we're looking for the surrogate. So at that point, we don't have to worry about confidentiality. We're on the hunt for the next decision maker. Those are the questions I had. Thank you.
You're welcome. And also at that time, part of the documentation, again, is for the person to, because it's a medical judgment each time on each person. One particular wound on 3 different people, one may be more life-threatening than the other, as you know. So just documentation again, you know, you've done as much as you can. You know, the EMTs check the glove box. You know, just things, the little blibs in the line will be more than what will help you out in the long run.
I'm supervisor nurse in clinical research unit, and one of the questions I had was in regards to the surrogates for research informed consent. must be a legal guardianship, correct?
Yeah, yes.
Or a durable powerful.
Yes.
For help.
It can't be just the neighbor who usually brings them groceries. Yeah. It really needs to be someone who's either been ahead of time designated or it's involved something written. It's usually for research. That was what makes it a little harder because we'd like to, in geriatrics, of course, like Alzheimer's research and dementia research, that just jumps right in the middle of that. So you need to just have a very tight control both on your protocol as to who's defined as a surrogate.
Is that Texas only, you're saying?
No, I mean, it should be pretty universal.
That's not.
Which it should, I just said it should.
No, it shouldn't.
Well, you know, the nice thing about the law, and you need to, okay, thank you. Well, I'll put it this way.
There are, actually, in California, the law allows family to give consent for surrogates and for research. So the law allows that in California. You are wrong.
Well, my slide was still, I'll research. My presentation was not wrong. That slide was in my Texas range prior to the other states. So I did not bring up that topic in California. So if there was any confusion as to when I was talking about any other state other than Texas, please start looking at the top where it says other states. And then that's when I went into other things, a default short of that of being Texas. So I'll just let you know. Now, I don't advocate that I haven't ever practiced in California. I was just trying to be helpful to folks attending from other states to have some informed consent generalities, whether again a defined consent definition or if it's more of an implied or brought together by a series of case studies. So again, you get what I'm not a lawyer, didn't advertise as one. So in each state, you need to know your laws, and that's what I mentioned. You need to know this law, the state that you're in, specific laws, and like your jurisprudence test that you have to take for each state. So, yes.
You probably went over this when I was a little slow this morning, and I just want to make sure I have your opinion clear on this. If you have a dementia patient that comes in for evaluation, they're clearly impaired, and there haven't been any legal steps taken for somebody to take over their medical care. Do you just go to a family member, or is that the next step? Is to get whoever the next of kin is available to provide consent, or do you not see the patient, or what do you do at that point? The patient's demented, but nobody's done anything about it.
A lot of times you need to really just check into your particular institution's policies, and if in doubt, that's the nice thing about an ethics committee. Most places are joint commission required to have an ethics panel.
Practice?
I'm sorry?
In private practice?
I would think that's you really need to seek legal advice if that's something you come across frequently. Again,
I do neuropsychological testing in dementia patients.
Yeah.
And they're all demented.
Yeah.
And most of the time they're coming to me because their families need to get documentation so that they can take partnership. Or
yeah.
And so that's always something sticky. I always end up just getting the family's consent along with theirs. But I'm not too comfortable with that. That's really the best way to do it.
Well, usually by the time you get guardianships, it's going to require a lawyer, an attorney, and you want somebody that's actually familiar with the laws. So by that point, usually some have to default to the attorney's legal advice, especially if they specialize in that area. So, and then also one thing important, by state, some states require you to report certain things that others don't. So you, again, got to be familiar with each state specifics.
But isn't the burden of the law to assume that the patient has capacity until proven otherwise? And so in this situation, if you were given I think what you're doing is very reasonable, getting the consent of the patient and the consent of the family. You're covered.
Patient becomes big. Patient doesn't become, especially in research.
And then, okay, so if it's research, it's
Yeah.
I wanted to ask if you came across any information about legal requirements for qualification to translate, or what do you evaluating that? Because I know even in the VA, I come across the incapacitated patient when the spouse only speaks English.
Yeah, and it really gets tough because, at least to be able to be a court interpreter, you have to have a certain certificate in the Spanish, proficiency. So at least when it comes to like legal proceedings, there's like a higher level than even just community languages. Specifically like, well, I know sign language. There's people who have to be certified at a certain level in American Sign Language before they can do any legal proceedings. So some of it, again, is just making sure that it's tough. And a lot of facilities have contract that people can call in and have a phone conference call, or because you're almost pretty well mandated to have some translation services provided for patients anyways. Whether you have it on site, someone that's gone through some and proficiency is available, or a lot of people are now using phone systems or televideo conferencing type available. And then that way the contractor has on file the proficiency of each of the persons for translating. And so it's a difficult thing, because just because you know, if you have someone from Spain versus, you know, around here versus Spanish in different languages and regionalities and accents and stuff like that, you really got to take that into account too.
We'll go here next.
Hi, I want to make one comment about in the VA, social work service is responsible for getting translators, and you can even contract to get somebody to come in who speaks the language. My question relates to utility, and recently I was involved in a conversation with family members where the medical power of attorney was going opposite to other family members, and the medical power of attorney was not involved, minimally involved, and other family members were very upset because the patient was going downhill. And they've been present for all the conversations with the medical people on a daily basis. And so I wanted to find out what your take is on the hospital's obligation to provide treatment in critical situations if somebody is clearly headed toward decline and death.
Yeah, I guess I tend to punt a lot of that to the ethics committees, just in the sense that they're a broadly represented group. They usually have behavioral medicine, they usually have nursing, they usually have the multiple disciplines, so that it doesn't seem like it's a one-to-one interaction or it's nothing at a personal level. So if there's any ethics panel members here, if you want to throw your shoe at me, I should put you in for a new consult, I guess. But really, I think it's just important that it doesn't ever appear that it might be at a personal level. If it ever seems like one physician has just decided that this is not good for the patient, then it needs to, you know, and part of it is helping the patient through the denial process. A lot of times I'll find out a person who doesn't want to be maybe like, you know, not seek medical attention. That just makes me want to go visit with them more as to why. Because in end-of-life issues, it may be because they haven't been talking to their son in 20 years, and there's some life goals they need to finish before they're willing to accept the end-of-life issues. So sometimes it just makes you need to go in there and ask, if it just doesn't seem right, then that means you need to dig a little more, not in a judgmental way, but to see if there's something you can actually help them with so that they can get through these. If it's like visiting family in Peru one last time, whether it's a son that they had a fight with 20 years ago and never talked since then. So I think it's important to just dig deeper, but then for overall ethics consult, just so that it gives a broad panel that most institutions have one that just covers you as well.
That's all the time we have for questions. We will take a break now and come back in 10 minutes.
Russell.